Hi, everyone. I'm Tina. I'm currently the Praina Leadership Fellow and a Doctor of Public Health student at the T.H. Chan School of Public Health at Harvard. And I was asked by several colleagues to record this lecture, this presentation that I recently prepared for health communicators in different health departments in the US who work at state, county, and city levels, so subnational level. So the lecture does have a little bit more of a US focus, not so many references to global health and other contexts, but I hope that you find it useful, and I, of course, would be very happy to answer any questions and address any comments that you email me with. So I prepared this presentation basically based on my experience. I spent the last 15 years working in global health, both at the World Health Organization and the European CDC. And I come at the challenge of the information ecosystem in public health and health misinformation with experience from a variety of different topics: digital public health, health information, evidence, disease surveillance in various health topics. And like many health professionals, I was very busy during the pandemic and afterwards. So until recently, I was the inaugural team lead for infodemic management at the WHO. And infodemic management is a term that's used in global health pandemic preparedness and response now in relation to health misinformation in emergency context. Now, today in this talk, there's only so much I can talk about the massive scientific and practitioner field of health misinformation that has been growing rapidly the last years, and the intersection of information environment and public health. So I put a lot of further reading, links to resources and tools into the appendix of this slide deck, and I'll put the link to this slide deck both in the description of this video on YouTube, and you can also find this presentation and others that I present regularly on my website, tinapurna.com. So you feel free to use the slides with under the Creative Commons license that they're published under. So let's start then. The modern information environment, it's changed not just how we access and search for and consume information, it's also changed how we feel about information and how we build social identities and meaning around different digital and offline relationships. Media is becoming increasingly digital and social. We've shifted to this 24-hour information stream, and it's mediated by our phones. We've been now conditioned by platforms to consume bite-sized content, and our information diet is determined by our access habits, different algorithms, and ad-based platforms. And all of this together is happening in the context of disappearance of local journalism, emergence of news deserts, and shifts in news consumption. Media has always had a profound impact on social perception, attitudes, and even actions. And I'd really like to also emphasize here that what's different now is the speed by which our digitized information environment amplifies narratives. So what you see here on the slide is an example of misinformation from 1938, when a radio play caused mass panic in the US. And back then, the radio was the new technology for reaching people inside of their homes. And on the right, you see two Taylor Swift fans talking about how their devotion to Swift and how she communicates with them is similar to QAnon adherence. And for the record, Taylor Swift is not related to QAnon. But this goes beyond radio plays and popular singers. the information environment is now as important for public health action as are the human, animal, and planetary environments. Now, part of the digitalization of the information environment and also the people inhabiting different information ecosystems is influenced by artificial intelligence. I'll point my talk to the public health perspective on artificial intelligence and health misinformation today. There's specific usages of how AI can be used by a public health communications practitioner in their work, but we also need to ask ourselves at the same time how AI can be harmful to public health communication as well. So for example, these are different ways that a health communicator could use AI, and especially the generative AI like ChatGPT in their work. It can be used in analytics of social media, in drafting messages and texts, editing and translating text, improving interactions with users, and it's also increasingly incorporated in all kinds of productivity and brainstorming tools. So I list here some of the tools that you could use for these tasks. But obviously, all these same tools come with limitations and biases. So that's why these same tools can also be either misinterpreted or misused. Now, the artificial intelligence technology and the used cases in different products, the technology is new, and we need to increase our skills in what different AI tools are used for. Because, for example, if we want to use ChatGPT as a source of fact or for fact checking, well, it wasn't designed for this. So we need to understand how generative AI tools are designed and where their limitations are. If we ask or if we try to use them not for the purpose they were designed for or where they're effective, we actually get in trouble and misuse them even unintentionally. Now, a communicator who's confronted with health misinformation might ask a question, how should we track it? And undoubtedly, someone will respond with a suggestion to use or build a magic social media dashboard. Now, I call it magic because we reduce the task to some dashboard that provides some data from social media that implies what people who interact on some platforms online talk about. But you can't tell in such a dashboard where the data came from. You can't tell how the AI algorithms analyzed and categorized the data, or what is the quality of the data and of the algorithmic performance in this platform. And you also can't tell what were the characteristics of the users that contributed their data to this analysis. In contrast, no epidemiological inference would be done on one data set of unknown quality of data and analysis. No epidemiologist would make recommendations without triangulating different data sources that inform the understanding of what is happening with the disease transmission and patterns and who it is impacting and how. Now, commercial social media listening and monitoring platforms, they were built to help marketers promote a brand. This entry point into analysis has very little or very limited utility in public health. For example, the social listening platforms like Meltwater and Talkwalker, they're designed to track how people are talking about the company and its brand. But in health communication, we're not selling the health services. We're aiming to achieve sustained behavior change that's a lot more complex and that can actually take shape in many different forms, not a simple conversion like buying a can of Coke, for example. So things that these platforms provide, like sentiment analysis, reach metrics, hashtag tracking, and listing of general top narratives that are circulating, they're not really that useful for public health action. Often they use data that's easiest to obtain from the internet and easiest to analyze with computational tools. So, when you analyze data from the internet, you will inevitably be limited to which platforms you will analyze, and you will inevitably also focus on the loudest people on the internet. We need to really keep in mind that only about 5% of people actually post content online. The rest are observers. And there's really little data on the observers and how exposure to content, such as misinformation as well, will have, what that exposure will actually do, what kind of impact it will have on their attitudes and behaviors. Analysis of social media platform data is also limited by the changing user base on the platforms that you might have to set up an analysis for. For example, the user base for X has changed dramatically in the last year and a half, and old analysis of old Twitter data is irrelevant for action now, given what the community on Twitter looks like now, who the users are, and what is permissible to be expressed there with the changed community policies there. Another thing to consider is that we need to remember that when you're trying to analyze and act on information dynamics online, you really need fairly fresh data. Now, even during the pandemic, even the CDC in the US had a 2-week lag time when they collected vaccine confidence data and when it was published. And especially when it comes to health information related behaviors, we need faster insights, and they need to be a lot more granular, because people's needs for health information and their narratives and the dynamics actually shift pretty fast in a community, especially when there's some kind of an acute health event that's occurring and that the community is experiencing. Basically, the bottom line here is that health-related challenges of the information environment require a change in our practices, in how we generate evidence, and also how we analyze data. Basically, we just can't rely on some AI platform to spit out some summaries of how users in the datasets are talking about health topics. Now, the good news here is that there are good examples of how to analyze and report on community insights quickly and on a variety of topics and in relation to health information needs. All of the ones that I'm showing here, so from WHO, from the CDC, from Brown University Information Project, they use AI for analysis of social media data, but they also triangulated this with other data sources to report on the insights with much greater confidence and reproducibility. If we over-rely on AI to conduct analysis, we discount the public health expertise that's needed to choose relevant data sources, assess their quality, analyze them, and interpret them in a way that's useful for public health programming. AI tools themselves are not designed to actually bridge that gap from basic comparisons and analysis to actually mapping it into what makes sense and is important and for public health action. Now, based on my experience at WHO and working with colleagues in other organizations in public health, I've identified and we've identified that there is a huge need for guidance on analysis and reporting of information environment issues. And this How to Write an Infodemic Insights Report in 6 Steps was co-published by UNICEF and WHO to provide simple steps any health department can take to develop rapid, reproducible, and useful insights. Now, this publication reflects the experience of communicators and other health professionals globally who've been dealing with health information inequity, health misinformation narratives, and health communication challenges in a wide range of programs and health topics like immunization, outbreaks, cancer, reproductive health, mental health. That's just to name a few. But there are a few key concepts in this guide that I wanted to highlight. First, there really is plenty of data available that illustrates the information environment, how people are reacting to it, and how it affects their health behaviors. There's plenty of data that we just never consider to access and analyze that are already available that don't require additional data collections that might be expensive or limiting. in their scope. Second, risk assessment approaches from public health can also be applied to information environment issues. This is key, just like risk assessment helps um, epidemiological analysis to hone in on the highest impact issues and also highest impact interventions or interventions that would have potentially highest impact. The same is true actually when you're talking about health information and information and ecosystem related issues. And third, if your data is robust enough, you can develop recommendations that go way beyond communications and community engagement and really roll over the insights and the feedback and the experiences, questions, and concerns from the community to inform also changes, adaptations, or corrections to how programming is delivered and designed, how products are accessible and delivered, and how services are experienced by patients and the community. So here's the QR code and the link to the manual. You're welcome to download and share this free resource and all of the accompanying materials widely. But then, of course, to borrow an old expression, there's many ways to pet a cat. And here are other ways of assessing health information needs of communities. I'm showing here 3 examples. They're all very useful and free. For example, on the bottom, the CDC developed a rapid community assessment during the pandemic to quickly assess a community's needs for information about COVID-19 vaccines in 3 weeks or less. A similar approach then can be used for any health topic that require fast insights. So that's a very useful resource. Now, what I liked how this rapid community assessment was used is when they used an extension of this protocol to involve adolescents to help assess vaccine confidence and misinformation that their peers were exposed to. So basically, adolescents were basically co-investigators and helped not just collect data, but also interpret and make recommendations based on it. On the bottom right, I link here to the video output of that project in San Mateo County in California. And I just really appreciate it because this project didn't only generate insights, but it actively engaged teenagers and the community they're part of in this process. What's really concerning is that with the explosion of interest in tracking online narratives and misinformation, we're actually also seeing the complete absence of any ethical standards or guardrails in data collection, analysis, and reporting when online narrative tracking and misinformation tracking is done for purpose of public health. Especially when a public health organization does this, we have a duty of care in how we work with community voices and how we present them in our work. This area of work in public health is really rapidly changing, and we're looking for all kinds of tools from other professions that we can adapt to public health. But the issue there is that when we're working on adapting tools that were developed for other purposes, or we're working with people who have analyzed social media for open source intelligence or fact checking, news reporting, digital marketing, they really have public health experience or expertise to filter their analysis through that. And when we're tapping into new expertise and when we're adapting new tools, we really need to help collaborators who aren't familiar with public health to actually bring that in. This is really important. And on this slide, I summarize some principles that we need to really take into account when we're working with communities' expressions of questions, opinions, their concerns, and the circulating narratives. Because how we collect the data, what data we choose to use, how we analyze it, how we report it and how we use it for health communication uh, really matters. Otherwise, we might end up unintentionally harming and stigmatizing the people that we're describing um, um, in our reporting that the narratives might be talking about or are being propagated by. So, you've all also had that one colleague who asked for a message that will solve some kind of communications challenge. And this is in the belief that a single message will be effective in changing people's minds or affecting their behavior. And now we all know this is not how things work. And really, we need to ask ourselves, well, when was the last time you changed someone's mind just with a simple message? If the public health problem is only partially a social one, then it's not going to be solved with only a communications solution, and whether the solution is AI powered or not. So in this example, for example, access and cost of healthy, nutritious food, or lack of access and high cost of healthy, nutritious food, they're not going to be addressed by encouraging people to eat healthier. So, the corpus of data that an AI-generated message relies on is not transparent, and algorithms that generate it are not transparent as well. So when we put both of these things together and you compare these three approaches that I'm showing here on the screen, the public health approach and the social marketing approach both rely on data collection, analysis, testing on humans to fine-tune strategies. So the evidence and the conclusions you reach from the first two are reproducible, but they're not reproducible in the AI approach in message generation, for example. So, and this is really how we need to be thinking about what is the appropriate use for generative AI in health communication. Generative AI really shouldn't provide a shortcut for quality health communications research. No one should be just copy pasting from ChatGPT prompt for messages on specific topics. And that's because ChatGPT wasn't designed for this purpose, and it isn't a public health expert. So it's the same. Like there's been stories about relying on Google AI. When you ask it, for a recipe for a pizza sauce, it would have suggested to put glue in your pizza sauce to keep the cheese from sliding off of the pizza. And clearly, in this case, the context of using the glue was wrong for the use case of human nutrition. Now, that isn't to say that you can't use AI tools to make sensible draft suggestions of messages to consider, but it shouldn't be the only tool you rely on to generate messages. And you need to pre-test any message before you use it anyhow. And this is whether it was AI generated or not. So, I mean, in summary, really, on one hand, AI lets you take shortcuts, which can help speed up the processes, but on the other, AI is also an unreliable source of content and analysis for expert-driven communication. And AI that's been released into the wild is already costing companies money. Companies are incorporating AI technology into all sorts of products and interfaces for communicating with people. But this is also why Air Canada is now on the hook for paying a discount that its chatbot promised to its customers. It's also not surprising that the same tools aren't well suited for public health. When AI is used, information is tailored for a specific person, which then leads people to trusting the information they receive through their devices more than they should. It's really easy to get bad health advice from digital sources. And here's just one example from when people ask their Alexa or Google Homes for help during their a home-based emergency. And what it comes down to really is that health communications messaging, when it's used, when we communicate about health, we make an implicit promise about the quality and accessibility and affordability and acceptability of health guidance and health services and health products. So if health messages are generated uncritically by AI, that can lead to false expectations that the advice is sound or that help is actually available. And then on the other hand, we need to also remember that we don't need AI to do a poor job in developing communication strategies. Considering, how easy it is to search for and find information from sources we might not find credible, but communities do. Communicators are facing really, really a changed information landscape nowadays. During the pandemic, we used CDC's Crisis and Emergency Risk Communication Manual. It's abbreviated CIRC. Great resource on the CDC website. And the author of the manual, Barbara Reynolds, has said that a good communication strategy cannot cover up for operational failures. And unfortunately, AI also won't help in a situation when there is an operational failure. I mean, what it comes down to is that trust is a rare commodity and it's easily squandered. Now, I see the public health working best when all the pieces that are necessary to deliver on people's needs and expectations from the health system are delivered in concert. The health system wants people to enact recommended health behaviors, whether it's getting your kid vaccinated or quitting smoking. But on the other hand, people also have wants and expectations of the health system, including demand for health information and health services and products. Like, for example, demand for STD testing or whether there's a boil water advisory and how it applies to them and for how long. When people feel that the health guidance is not in their best interest, or when they're looking for information but they can't find it, or when they need access to health services that aren't offered, that alone can erode trust in the health system, in the products, and in the health workers. And in all of that, AI-mediated misinformation can add more noise into that, to seeking health information and to finding where to get health services and health products. We need to keep in mind that there's no way to ever completely eradicate misinformation or even slow down the internet. And that really isn't our goal. We really need to focus on building resilience in individuals and communities against misinformation. And we start that by becoming a public health system that is worthy of trust. There's also no public health intervention for trust. You can't buy it, you can't stock it, and you can't load it into a truck. But what we do know is that misinformation can be corrosive to trust. There is this temptation to find a magic solution or a quick fix to trust challenges, and that often ends up looking like a project or a mission to address misinformation. But I really would say here, beware of easy solutions that are offered to address health misinformation. All of these responses and quick fixes that I show here on the left, they ignore public health principles when they're trying to address that. It's what's really a social issue that impacts our ability to deliver on our public health mission. Now, there are very few people who work at the intersection of the information environment and public health now, and I hope that the number increases. In public health, we're lagging behind actually when it comes to developing tools and approaches on how to respond and to prevent health misinformation. There's still really a long way to go before the toolbox of an infodemic manager or an infodemiologist is as diverse and comprehensive as that of an epidemiologist. But while we're doing this work and while we're building this, we really need to remember basically the principles and values of working in public health in general and how this applies to thinking about the challenges of the information environment, responding to confusion, responding to people's questions and concerns, responding and mitigating health misinformation. And it comes down to these principles here: doing no harm and preventing and reducing harm as an emphasis, communicating what's known and what's not known, using best available evidence, which means we use triangulation of imperfect data sources, protecting the vulnerable as a priority, evaluating as we implement, which comes down also to using data in an agile and nimble way to adapt programming and interventions as we're implementing them. Using multi-level interventions, there's really no public health problem that isn't complex and doesn't have aspects that and attributes that basically link to multiple levels, all the way from the granular level at the individual, then looking at the family community, looking at the health system or society. And that also means that such problems require multi-level interventions and strategies. Health misinformation and the information environment are no different here. And of course, the principle of involving community of focus, all the way from understanding the problem, designing an intervention, implementing it, and evaluating it is really, really important. I mean, what it comes down to is that we should demand and expect better tools and solutions that are evidence-based, multi-level, and embedded in public health practice. And this brings me to several key takeaways that I've prepared for you. So the first one is that we might be worried about health misinformation and how it propagates in communities that we're trying to serve, but really the best offense is a good defense, and we must ensure that we're providing credible, accurate health information first. For example, in the US context, only 8% of the Veterans Administration websites are accessible for people with disabilities, and this directly impacts their clients who have a higher rate of disabilities compared to the general population. So a web design that works for a commercial website, when it's applied in a public health context without looking specifically into the needs and the impact and the audiences of that particular health information channel, that design really doesn't work for public health organizations. So here's some ideas for what these basics would be, and there's plenty of free tools online that can help you audit your digital footprint in different areas that I'm mentioning here. It's also important to note that your social media channel may be more prominent and accessible than your website, and it may be the first referred to by your audiences when they need health information. So for example, when there's a forest fire, when you need information, people aren't waiting for the press release to be uploaded to the county emergency services website. So really thinking about the editorial policy, the content policy, and thinking about the digital content syndication, etc., and organic diffusion of content is really key in order to even participate, that your organization even participates appropriately and effectively as a baseline in the digital information environment of today. The key takeaway two, I actually think this slide speaks for itself. This is a popular cartoon from XKCD that summarizes my feelings about the futility of fact-checking the internet. Are you coming to bed? I can't, this is important. What? Someone's wrong on the internet. Now, the challenge we have in addressing health misinformation is that there is no one final arbiter of truth for health information online. So we can't be alone trying to address health misinformation, and we need to partner. Here's an example from the COVID-19 times that still should resonate today about the typical misinformation narratives associated with health guidance. Now, not all of these narratives may be misinformation. Some might come more under the heading of personal experience or expressing questions and concerns, but they are typical buckets of health misinformation that you will likely see across many health topics. Now, the first two, the misinformation about the development, provision, and access of healthcare services and products, and about the safety, efficacy, and necessity of health products. These two are the buckets that can be addressed by the health department because they're specific to how the products are developed and how health guidance is developed, which are both under the purview of the health system. But I wouldn't recommend any health department trying to tackle the other four buckets of health misinformation. And you really need to ask yourself, well, who would you work with to address the other four categories? Now, don't assume that the health information that you share will be seen as trusted and credible by your audiences, and instead partner with organizations and voices that are trusted, and partner wisely. There's many organizations that I'm showing here that are trusted and are integral to people's day-to-day lives that you can partner with. But there's also two other things to consider here. One is, do pick your battles because you have limited time and resources and sometimes don't have also the right partnerships in place to address a specific information challenge. And second, you or your organization have likely already experienced harassment and abuse of health staff members, including online. And happily, there's tools available, such as the Digital Safety Kit for Public Health from Harvard. But I actually think this goes way beyond kits, and it requires that we consider protection from doxing and online harassment as part of our occupational health and safety programming and work. So prepare also the institution and institutional capacities and policies in order to protect staff members from harassment and online harassment and doxing. Key takeaway number 3, in the public health fashion, we also need to focus on prevention. So think like a fire marshal, not like a firefighter when it comes to addressing health misinformation. You can really build resilience within the health system and within communities. Now, instead of focusing on mis and disinformation, focus on the low-hanging fruit here, which is addressing questions, concerns, and information void. Here, you see a rough continuum from the left to right, from questions, concerns, information voids, and then to misinformation and disinformation. It's a continuum of evolution of sort of jumping through if questions and concerns of people are not met, are satisfied, responded to, if people are searching for information and they cannot find it, then there's a much likelier chance that they will search and turn to other sources of information that might be lower quality and then might not be not contain credible and accurate health information. Therefore, there's a higher chance that people will come across and find misinformation and disinformation. So what's represented in the green box? Questions, concerns, information voids, and a little bit of misinformation. These tend to be more common and are easier to address by health departments. And in a lot of instances, mis and disinformation, so the rest, is much harder to address by health departments directly. But there's much more you can do on the left side of this diagram than on the right. Meeting people's health information needs is a lot more proactive and preventative than if we hear misinformation and then try to take action against that. Because by the time that people hear misinformation, it's probably very widespread and it's not likely to be affected by interventions at the local level. So what are some of the preventative actions that you can take now? These are some suggestions. What I'd want to point to is a commentary from the Harvard Misinformation Review that was discussing generative AI and its relation to harms from misinformation. Basically, the authors discuss there, and I do recommend that if you're interested to read this, that it's yes, generative AI makes it easier to create misinformation, which could increase the supply of misinformation. But what we see and what all of the evidence is pointing to, that just because there's more misinformation that is circulating, that doesn't necessarily mean that people will consume more of it. And instead, we really need to be thinking about not the supply of misinformation, but that actually consumption of misinformation is more limited by demand for it. So we need to focus on the demand, and preventative action need to be really thinking with that nuance in mind. And this brings me to the next point, key takeaway number 4. The usual health communicators playbook is missing a few chapters. Insights from understanding the modern information environment can really benefit more than just the communications team in the health department if you lean in really to listen to the information and health needs of communities. Then potential strategies and priorities on what to do will naturally surface. So you need to use the same approach when you're looking for a menu of strategies you can use to address health misinformation as well. Now, this is a small snapshot of the results of a massive evidence gap map review that I led at WHO. The font is small, but this is a list of 20 tried and tested strategies to address health misinformation. This list actually, when you look at it, might be more expansive than you expected because it crosses several intervention categories. So it includes monitoring, science and health communication, education and training, engagement, and also law, regulation, and ethics. And these are the missing chapters of your playbook. I also wanted to leave you a little bit with some suggestion to take to your manager. The recommendations I put here are designed to be practical and tangible. And I promise you, it's far more satisfying than any magic dashboard you might be offered to look on a weekly basis. So these are practical things. Fix your health system's digital footprint. Introduce new ways of developing and promoting health content, including experimenting with AI responsibly. Integrate health misinformation prevention and response into emergency structures before the next emergency. Leverage community and digital insights generation in routine for the highest priority health policy areas. If you have this capacity in place, you can always surge it in an emergency, or you can pivot it to the next priority that is part of your strategy, health system strategies. It's also important to train healthcare workers on how to communicate more effectively online and offline with people that they care for, and also to address misinformation. We, as the health system, need to do a much better job of protecting healthcare workers from online harassment and doxing. We also need to promote digital information, media and science, and health literacy. And we should really, as a routine, start incorporating metrics and indicators on information environment into regular reporting. Now, I encourage you to experiment with AI tools here, also because it's nothing to be scared of. I just ask that you broaden your boss's horizon, not to see it as a panacea for all health misinformation problems. And also, AI-facilitated health misinformation isn't the apocalypse. It's just a symptom of a new digitized society, which is changing how we relate to one another. And with your help, your health department can take proactive steps to meet this reality, to fireproof the system, to support health professionals and protect people's health. I also was asked about, well, how do we fund this work? It's challenging during the pandemic. Work related to health misinformation, to infodemic insights was funded from emergency response funds, but that has surely and slowly gone away as health systems have pivoted back to their routine challenges and have focused on um, uh, resurging back from pandemic impacts. So yes, funding this work requires that you are adaptable to health topics and linking these health topics to other health system functions. So this really means that you need to tap into partnerships and funding in topics other than emergency preparedness, even if that's where you were used to getting funding for this work. So you need to develop capacity for insights generation by partnering with other teams. And think of it this way, you can offer those teams expertise for either routine programming, like immunization, adolescent health, injury prevention, etc., or for high priority policy topics that your organization or health system may have, like opioid use disorder, nutrition, or suicide. And you can start these partnerships little by little. You can start first with ad hoc reports, and later you can routinize them. And you can start also in collaborating with these teams in design of interventions, where you bring your expertise from the health misinformation and information environment space, and they bring the knowledge and the context of that particular field of public health. The other thing is that on a strategic level, you need to think about first from the frame that you built for your team. What kind of breadth of expertise and intervention capacity you need in order to be able to start providing that type of expert partnership to health programs, different health programs. And then you partner with those health programs to apply for grants that supports those capacities. So it's really important that when you do this and when you apply for grants, to be not to overemphasize that whatever you're applying for is presented as a strategy, like a magic fix solution strategy. We often apply for grants that are very narrow, that have very narrow specific aims, but it's really important that as you implement this, you need to implement it in ways that strengthen also the broader capacity in the system, not only that one grant aim that you're funded for. And lastly, I was asked to a little bit comment on, well, what do teams that are resourced differently, that are of different sizes, that have maybe different buy-in from their leadership, what can they do, or what they can start with, what should they emphasize? It's during the pandemic, we kind of talked about this with the metaphor of one lone person on a mountain bike running through a rough terrain full of obstacles with a small toolbox that they could bring along and apply in order to address misinformation and promote resilience to it. And then once there is a little bit of a team, they have a bigger toolbox that they can transport and drive in a sturdy 4x4 in a much nicer terrain. And once you are fully funded, you have SOPs in place, you have relationships in place, you have buy-in from senior management. That basically means you're driving a luxury vehicle in on a perfectly paved road. So if you look at these three, I included in my slides also some suggestions that I have based on experience and discussing with colleagues throughout the pandemic, and their experience on developing these capacities, many different places around the world. I've included 3 slides, one each for each of these resource and working context, operational environments, so to say. Even if you're just one lone person on a mountain bike in a really rough terrain with very small toolbox, you can actually start work even at this level. And this means that you start small. You work with the health program staff to identify questions that can be answered through monitoring of the information environment and insight generation. You start first by identifying what data sources exist already that you can use, and focus on understanding populations experiencing vulnerability first. So prioritize that. Leverage different partners and work side by side with epidemiologists to improve coordination. So I'll literally learn from them what insights they're missing and brainstorm how you might be able to help out with that. And from the strategy and intervention point of view, basically identify a subset of those 20 strategies to address health misinformation that I was showing, and look at what actually would make sense in your context. I would advise not to focus only on social media, pre-bunking and debunking. Pilot other strategies as well. And it may be that your access to social behavioral resources may be limited. So really work through your partners and contacts to develop relationships and access to such data. But do your best to make it an effort to evaluate as you're doing, and share your experiencing with others that work in health misinformation. So here, making a network with people who are doing a similar job, etc., so that you have some peer support and advice. It can be really useful. And even if you're just one person and you're very lowly resourced, there's no reason for you not to do some basic user testing to figure out how to improve existing channels for communication, including the health department's website and social media presences. Really focus on making small and doable improvements. When you're driving a sturdy 4x4, you have more people, and that means that you can add more data sources, especially those with better access to populations that are experiencing vulnerability. You can set up a team with dedicated staff that then monitors the information environment. You can actively work to create demand for these insights. So you start strategically engaging more with other teams, and coordinate then with community-based organizations to share insights with them, as well as to inform communications and programmatic activities further. On the strategy and intervention level, this is where you can start really using participatory research approaches in design and development of interventions. Start looking at multi-level interventions and their implementation. Collaborate with behavioral scientists and epidemiologists within and outside the health system. So advocating for stronger data collection and indicators in communication activities. Co-develop guidance with communities, so focus where possible, etc. And when you're driving a luxury vehicle, this is where the dream activities would be in the insight generation. Now you have resources to develop new data sources where you have gaps, data gaps, where you have limited availability, and invest in routine data sources and representative data collection. Regularly assess the needs of insights report stakeholders and insights products and modify accordingly. Provide ways for partners and networks to use, edit, and remix messages for different formats. Promote regular recurring reports with ways to take action that include recommendations for communications, messaging, and health programming. And then from the strategy and interventions point of view, this is where you can build users into entire design cycle, from problem definition, ideation, development, implementation to evaluation. Develop robust research designs and protocols to evaluate interventions. Really start developing tailored insights and products for different communities. Support implementation, science, and evaluation of health misinformation prevention and mitigation interventions in specific. And always keep in mind to seek feedback from stakeholders on how useful the insights are and interventions are for specific communities. So this is the end of the presentation. I tried to give you just a little bit of flavor of how multidisciplinary the field of health misinformation response really is. It might feel overwhelming when you're trying to make sense of all of the frameworks and the menu of interventions and you know what potential solutions and strategies should be. But just know that even if you're only one person in a tiny office, there's still things that you can do to make a dent. And I hope that you found this helpful. I'd love to hear your reactions and ideas on how to better address health misinformation. You can email me at this email address through my website, tinatbrunat.com, or you can find me on LinkedIn. So I'd love to hear from you. On my website, I also collect resources, tools, interesting reading papers, reports that are relevant to addressing information environment challenges and emergencies, so for infodemic managers and infodemic management, and also more widely in routine public health programming. So take a look, and if you have any suggestions for me to add, I'm happy to receive that as well. I will add a link to this presentation in the comments in the description part of this video on YouTube and on my website. So I do recommend that you check out the appendix or the additional slides that I prepared and put into the presentation because I added some recommended reading, a few podcasts that might be of interest to you on the topic of misinformation, health misinformation, and what we can do about it. Some links to different commentaries and papers that might be useful in to think through and to challenge some of the impressions sometimes that we get from the current media reporting about the science of health misinformation, so that you think through a little bit of where the diversity and where the evidence and the effectiveness of some of the strategies is. And I also added quite a lot of links to different kinds of tools. If you're working in humanitarian setting, what might be some tools that might be useful for you. If you're working in health emergency context, in acute mass health events, what might be some tools and strategies and reference documents that you can refer to, etc., etc. So there's actually quite a lot that has been developed the last 5 years in public health by different organizations, and there's plenty to learn from. So check out the appendix. Hope that it's useful, and thank you for listening.